Thanks everyone for joining us today. Really appreciate your time and excited about the topics we'll cover here with Dr. Bob Ratner and Steve Martin. And just quick intros on our panel. Dr. Ratner is the Chief Medical Officer of Verta Health. Prior to Verta, Dr. Ratner was also the Chief Scientific and Medical Officer for the American Diabetes Association. Dr. Ratner is a professor of medicine at Georgetown University Medical School in Washington, D.C. After 35 years of active patient care and clinical research in diabetes, he did serve as that Chief Scientific and Medical Officer at the ADA. So we're excited to have him on today. Also on the line is Steve Martin. He's the managing partner of Paxton Advisors, LLC, a business advisory and consulting firm based in Omaha, Nebraska. Previously, Steve Martin was the president and chief executive officer for Blue Cross and Blue Shield of Nebraska, leading the company's executive management team for over 16 years and serving as a member of the board of directors from March 2002 until March 2018. Steve Martin currently serves on the board of directors of the Blue Cross Blue Shield Association in Chicago and serves as a chairman of the BCBSA Brand Enhancement and Protection Committee. Martin also serves as a board director for Prime Therapeutics after founding the company in 1998. And then myself, Steve Hastings, I am our health plan sales leader at Verta, based in Chicago, and really excited to walk through all of the great stuff that we have here regarding diabetes and the current environment that we're in. So with that, I will let Dr. Ratner take over and give us a little background around our current environment, COVID-19, and its impact on diabetes members. Bob?
Good morning, everyone. It's a pleasure to be here. Just to give you a bit of background of why I joined Verta, I've been a practicing endocrinologist doing clinical research in diabetes for almost 40 years. I transitioned from being an investigator, including on the Diabetes Prevention Program, to becoming the Chief Scientific and Medical Officer at the American Diabetes Association. I spent 5 years there with oversight over the medical standards of care for diabetes, in addition to all of the research and scientific publications. I joined Verta because I see a significant advantage to the healthcare delivery system that Verta provides. And the intervention, as you'll see in just a bit, has a profound beneficial effect as we move forward. So I'm trying to, there we go. So the time of COVID-19 is clearly a very different circumstance for all of us, but people with diabetes are particularly concerned. 25% of the individuals who get hospitalized have diabetes, and 20 to 25% of those who die have diabetes. And if you simply screen individuals for their concern, people with diabetes clearly have a greater concern than most others do. Oh, too fast. This is important because what we've now learned is that controlling diabetes has a profound effect on hospitalization, on ICU admissions, and even more profound on mortality. Here you can see from a very large study in China that individuals who came into the hospital with glucose levels below 180 had only a 1% mortality rate. But if the glucose was greater than 180, the mortality rose to 11%. 1 in 9 individuals died within a 4-week period of time. Controlling diabetes matters. The difficulty is people don't want to go out to their doctor's office. They certainly don't want to go to an emergency room. So our ability to provide telehealth and control glucose without the need for the patient to even leave the safety of their home is critically important. So, how do we come across the standards of care? The American Diabetes Association has been publishing standards of medical care for people with diabetes since the late 1980s. We are one of the few organizations who update their standards of care on an annual basis. And over the last 3 years, we've actually started updating it in real time as new studies come out. This is a very, very rigorous process. A professional practice committee within the American Diabetes Association is charged with reviewing data and writing the standards of care. There is no conflict with industry of any sort. We are not driven by influence, we are driven by data. And everything within the standards of care has to be peer reviewed and accepted. So we've grown from a 3-page standard of care in 1990 to, in fact, now having over 100 pages with over 800 references within this. For those of you who are overcome by this massive tome, we've actually toned it down a little bit, and our primary care group within the American Diabetes Association has been doing a standards of medical care for primary care practitioners, which in the past has been published in the Annals of Internal Medicine. So what is the process here? Data are reviewed from peer-reviewed journals, and those issues that are truly different get incorporated into the new standards of care. Now, we can see how all of this has kind of evolved over time. In 1994, I was involved in the development of the NIH Diabetes Prevention Program. I was on the steering committee and the planning committee. We carried out that study for 19 years. And in 2003, we've done it now for almost over 20 years. In 2003, we published the primary outcomes in the New England Journal of Medicine. And in that year, all of the findings of the DPP were incorporated into the standards of medical care. Now, it takes a while for research data to get translated into clinical management. And it wasn't until 2015 when the Centers for Medicare and Medicaid Services approved the CDC Diabetes Prevention Program for Medicare coverage. And so you can see this transition of incorporating new data into the standards of care and then trying to get them implemented in the community. In 2019, the ADA incorporated a therapeutic carbohydrate restriction diet into the clinical outcomes for the first time. This was based upon a controlled clinical trial that Verta carried out and published, and we'll look at some of those data in a bit. So 2019 was the first time that this therapeutic carbohydrate restriction was incorporated into the standards of care. It has been continued in 2020, and unless there is additional data, it will continue because it is data supported. So what we're looking at is a combination of therapeutic carbohydrate restriction together with medication deprescription, because if the glucose levels are coming down due to the nutritional intervention, it's imperative that we decrease drug therapy. We can only do this in connection with a continuous remote care model, where we are able to decrease therapy in real time as glucose levels come down. We have the data to support all of this. A variety of papers from short-term outcomes to 2-year outcomes, looking at a variety of factors beyond just glucose control, including sleep quality, liver function tests, cardiovascular risk factors, and lipids. So clearly, the data exist to support the standards of medical care. So how does this affect people who are enrolled in Blues plans. These are your data. Now, we've censored it at 90 days in order to have sufficient numbers here. But what we're doing is we're now getting up into over 200 individuals who have been followed for 90 days with, as you will see, amazingly complete data. What you can see is our individuals came into the program with a mean hemoglobin A1C of 7.9 and a weight of 224 pounds. These are probably the majority of the patients that you typically see. In just 90 days, what you see is a 1.3% fall in hemoglobin A1C and a 13-pound reduction in weight. This is the population that you're seeing. Now, for the actuaries in the room, what you're really interested in is population shifts as opposed to simply looking at mean changes. So in the top bar, what you can see is the distribution of A1C values at entry. 21% of your patient population failed the HEDIS measurement of an A1C less than 9. 21%. An additional 14% are out of control between 8 and 8.9. And what you can see is that only 18% actually were in the normal range, and 15% were in an acceptable range as defined by the American Diabetes Association. In 90 days, what you see is a phase shift in this patient population. Now, only 1% fail the HEDIS mark of A1C greater than 9. And 58% have now moved into the non-diabetic range of A1C. And in fact, what you're now seeing is 74% meet the ADA criteria for tight glycemic control. What about weight? Here you're looking at distributions of BMIs from normal in the dark green up to morbidly obese greater than 40. Now, one of the issues that I want to emphasize to you is that when individuals come into Verta, they stay. We only have 1% missing data at baseline and 7% missing data at 90 days. We have a 97% retention rate within the Blues program at 90 days. People are not coming in and dropping out. They're seeing beneficial effects quickly, and they're staying in. Again, what you're seeing is a phase shift towards normality in the BMI, with 42% being severely or morbidly obese at initiation, and only 29% being in the non-obese range, overweight or normal. Now, normal and overweight constitutes 38% of your patient population, and only 12% fall within the morbidly obese range. We're accomplishing this by decreasing medication utilization and medication costs. From a patient perspective, that's simplifying their regimen and it's keeping money in their pocket. From a health plan perspective, you're hitting your HEDIS goals with a reduction in pharma costs. What you can see is a range in complete elimination of drug therapy from 17% to 83%. But even in those individuals who don't completely eliminate their cost, we're still seeing a reduction in dose. So for example, with insulin therapy, 14% have completely eliminated insulin therapy in 90 days. But in the other 86%, they've reduced their dosage by 44%. So clearly, your patient population is doing exceptionally well in a Verta program. How does this compare to what we see long term? Obviously, 90 days doesn't give you sustainability, but only time will tell how the blues patients can proceed. These are our 2-year controlled clinical trial data. What you can see is that usual care, A1C goes up, body weight goes up, drug cost goes up. A profound fall in A1C within the first 90 days continues for a year with only a very moderate increase in A1C by year 2. Body weight drops profoundly and stays down. And what you can see is even with the very mild increase in A1C between year 1 and year 2, drug costs actually stay down. So we've got a variety of different outcomes that we can talk about. What's important to you? Weight comes down, A1C comes down, pharma costs come down. But we also show changes in blood pressure, changes in inflammation, changes in lipids that are all beneficial. We see a partial reversal of liver disease with liver fat scores and fibrosis coming down. And we see clearly that patients are doing better. These are your data. These are your patients. We think we're doing well by them. Thank you.
Thank you, Dr. Ratner. Appreciate that. And appreciate anyone that has questions about the material covered so far. Feel free to provide those questions and we'll have time at the end. Next, we will have Steve Martin, former Blue Cross Blue Shield of Nebraska CEO, talking. And just to clarify, in the spirit of transparency, which Verta always falls in that camp, Steve Martin did retire from those boards at Prime Therapeutics and the association in 2018. Also, for transparency's sake, he is on the following boards today: Wellframe Incorporated, PredictImmune Incorporated, and then also serves as an advisor to Verta, Haven Health, and Redirect Health. With that, I will let Steve Martin take over. Steve?
Thank you, Steve, and thank you, Dr. Ratner. Well, before I get into my story, we'll go through a few slides to just show that my experience when I led Blue Cross Blue Shield of Nebraska, diabetes in Nebraska was very similar to the rest of the country. 11% of the population had diabetes, 36% had pre-diabetes. The cost to the state was about $2 billion a year. It's still about $2 billion a year. And total costs attributed to diabetes on average between 19 and 64 PMPY, about a little over 20,000, close to 21,000. So I think I'd like to start with my story. I was first contacted by Verta in early 2015 and actually was intrigued by the concept, but the data was very limited. And also because I had been a type 2 diabetic for almost 20 years. And it's very prevalent in my family. In fact, everyone over 40 in my family who survived over 40 has become type 2 diabetic. So the genetic link appears to be very high for me. But I also believe that the only path was compliance. And I would usually run a high A1C, but right on the edge. I tried to follow the ADA protocols. My physician solution every other year was a slight increase in medication over 20 years. I could see I was headed for the path eventually of being probably insulin dependent in my late 60s or 70s. In 2015, I had a head injury. I bumped my head on a cabinet, which resulted in a very slow bleed in my cerebral cortex along the left motor nerves, or the motor nerves on the left side affecting my right side. What occurred about a month later in October was my first seizure occurring because of that slow, long bleed. It was surgically inoperable, so I had to endure it. And I was hospitalized for a week. And over 5 days, I had continuous motor seizures, almost one seizure in every hour or less, over 5 days until it could be medication controlled. It resulted in two things. One, temporary paralysis on my right side. And the second, on the last 2 days of hospitalization, I incurred what we finally found out were 2 insulin reactions. The hospital center I was in, the protocols were to move patients who were type 2 to short-term insulin. So the only answer anyone could give me was theoretical, that perhaps the intensive seizures had somehow broken my insulin resistance, muscle insulin resistance. But within a month after my rehab, and I was rehabbed and back to work in about a month and a half, and walking, and my paralysis subsided, and then my type 2 symptoms began to return. Shortly after that, I was contacted again by Verta about a pilot project. Not seeing enough data and still being a bit of a skeptic, I decided, well, if something reversed my type 2 diabetes temporarily, maybe there's something to this story. And I stopped, just blocking it and falling back on conventional wisdom. So I decided, for the good of me and my customers at Blue Cross, I would enroll and self-finance. I paid $5,000 to join Verta. I was impressed with the virtual education program, and my busy schedule at the time, I thought I could maintain it and work with it. Within 90 days, my personal physician, who followed me along with the Verta physician, my personal physician began to realize he had to start reducing my medication. And by the end of 6 months, I was off of all diabetes medication. My blood pressure medication had been cut in half. My A1C was in normal range. My lipids were low normal to normal. And so I was removed from lipid therapy and all but metformin, which my physician cautiously wanted me to stay on for the rest of the next year. By the end of, by mid-17, I was completely off medication and have remained so ever since. One other potential, we don't have evidence for this, but one other effect that occurred prior to going on the program, I was a college athlete and suffered multiple knee injuries and a couple of shoulder injuries. And I had chronic tendonitis in my shoulders. And when I did run or walk extensively, my knee joints would inflame. After a year in the Verta program, the inflammation subsided, the tendonitis went away, the planned shoulder surgery that the orthopods had planned to do was discontinued, and I began to be able to work out more consistently, and I work out 6 days a week now since that time. So my health overall has improved. So as we look through the healthcare system, I realized at that time that I needed to understand why we didn't have more solutions for reversal. And so my message is, I know very well what the economic incentives, and I think sometimes they can be misguiding. I do know from my history of a PBM and understand the pharmaceutical financial incentives for rebates and other financial incentives for diabetic compliance mean the only choice most of our customers have is a medication path. My plea to you is, if even a smaller percentage of your customers could benefit from reversal, why wouldn't you engage? Verta's financial model is one of taking risk, and they have a variety of ways of taking risk, from complete risk to a variety of other ways to work with a health plan. So Verta works, and if you don't have a reversal strategy in your repertoire, think about what might happen years from now when customers realize they could have benefited from it, but you didn't add that to your repertoire. As I said, the risk is low. The customer response is very high for those willing to engage, and their ability to retain customers is incredible. I can speak from 3 years of being on daily aspects of the program. Today, I just submit data on an intermittent basis, but I can say that the program sustains long-term. I feel better now, about to go into as a new emerging Medicare beneficiary. I feel better now than I did when I was 50 years old. And I attribute that to the help that the Verta program gave to me. And as I said, compared to the risk that customers in the health plan are seeing every day with medication, especially new medications that provide much more serious side effect risk that patients who've been on medications for a long term are being exposed to, I implore you to consider adding this to the repertoire for the good of your customers and for your bottom line.
Thank you, Steve. Appreciate your words. And we've got a lot of great questions rolling in, some of it around how it works and sustainability, positioning, offering this to members. So myself, Steve Hastings, sales leader for health plans at Verta Health. I'll just walk through about a 7 to 10 minute run through of what Verta is doing and how we're doing it and the positioning. And hopefully that answers a lot of those questions. We'll still have around 15 minutes left over for Q&A at the end. So with that, let's move into the first slide here. So diabetes reversal, Dr. Ratner mentioned what this was, but just to hit it home, the definition of diabetes reversal is getting a diabetes patient below that 6.5% A1C threshold without the use of any diabetes-specific medications. That's with the exception of metformin, which is considered a low-cost drug and used for multiple conditions, not just diabetes. And that's what Verta is doing at scale across the nation. And we're filling in that gap for health plans and employers' diabetes solutions to members right now, because there is no other solution saying that silver bullet message to that diabetes member. Do you want to get off of your diabetes medications? Obviously, everyone on this webinar knows the financial and clinical impact of diabetes. Here at Verta, what we're doing at scale with our diabetes patients and reversing their diabetes, we see this as an epidemic that can be stopped and reversed. How do we do that? There were some questions coming in around DPP and diabetes management and where reversal fits. So again, getting people off of those medications has such a cascade of benefits, not just for the plan sponsors from a clinical and financial perspective, but impacting that diabetes patient and their personal lives. Many people on this webinar know somebody with type 2 diabetes, and you can imagine the impact it would have if they weren't beholden to those medications. So plans right now are offering prevention centered around weight loss and management, usually centered around medication adherence and general diet and exercise. Reversal is leveraging this provider-led medical nutrition therapy and de-prescription of medications to safely normalize blood glucose without the use of those meds and improve metabolic health. So getting people off of those meds and offering Verta, that is the gap that we're filling. And we are doing it, as Steve Martin said, at 100% at risk with clinical and financial outcomes being the only way that Verta retains its fees. Just to check the box here, obviously we've been cited, as mentioned before, in the American Diabetes Association Standards of Care Guidelines. We also have third-party validation with our clinical outcomes. And Verta is not just a telehealth provider licensed in 50 states. We also have all of the tech infrastructure that you would expect from a vendor to roll this out to all lines of business. So although Verta is set up to do remote monitoring and management of medications, and prevention of diabetes, where you, the plan sponsors, see the most impact on clinical and financial outcomes is on the right here. Type 2 diabetes reversal, leveraging this provider-led medical nutrition therapy. That's where you're going to see the rapid and sustainable change in your diabetes membership. These are just a few case studies, and hopefully you know that Verta is rooted in data and outcomes. We have all of our peer-reviewed published papers on our website, and we're happy to share individually any other outcomes that we have. But this is just showing how we're consistently reversing diabetes across multiple populations, different demographics, male, female, young, old, blue collar, white collar, different social determinants and geographies around the nation. We're showing consistent A1C reduction without diabetes meds, and then significant weight loss. And the weight loss is a very unique ancillary benefit of Verta, but the outcomes aren't so ancillary. It's because we don't ask Verta patients to lose weight to reverse their diabetes. So it's not the focus of the treatment, but we still see weight loss that is sustained over years, better than most weight loss clinics. So this is the money slide of how Verta works. On the left is this well-founded proprietary medical nutrition therapy based on carb restriction. It's individualized down to the N of 1. So this works for different backgrounds, social determinants, dietary preferences, vegans, vegetarians, pescatarians. So we will map to all of that. And then we apply that nutrition therapy that we know works to our continuous remote care platform, this virtual care platform that allows our care team, providers and health coaches, to be able to interact with patients on average 2 to 4 times a day. That's an amazing stat in terms of interactions with patients. You compare that to the typical 15-minute visit every 6 months with your PCP, you can see how that contrasting paradigm just isn't tenable for diabetes reversal. So we've leveraged technology to interact with patients daily. We ship them durable medical equipment so that they can submit weight, glucose, ketone readings, subjective data like hunger and cravings. And then as their blood glucose does start to come down rapidly, our providers are deprescribing unnecessary diabetes medications. This is what makes this provider-led medical nutrition therapy safe and effective. And then we are reporting that to their PCP so that this stays integrated with their existing care ecosystem. We're not just doing this for those patients that are ready to reverse. This is for multiple personas, multiple experiences. You can imagine the wide range of acuity levels, readiness levels to change. We are getting that lowest hanging fruit of people that are ready to reverse and change their lifestyle and make that behavior modification. But we're also getting a lot of those folks that have been frustrated with diabetes management not working. And many people on this webinar know, even if you do medication adherence and general diet and exercise and meet with your PCP once every 6 months, over the long term, you're still going to see A1C slowly climb, meds increase, costs increase, symptoms increase. And so we're getting those people that have been frustrated. On average, somebody's been dealing with their diabetes about 8 years before joining Verta. And then in many cases, we're rapidly reversing their diabetes in a matter of weeks or months and sustaining that. We're also getting those folks on the right that are disengaged with their health, or because our analytics team is leveraging claims data, we can actually target those members that didn't even know they had diabetes or didn't know that they had elevated glucose levels. So we are pulling in multiple personas now that diabetes reversal is an offering that they have available to them as an option. We're addressing key social determinants here. The obvious one is that because we're telehealth licensed in 50 states, none of these diabetes members need to drive to a doctor's office to interact with their Verta care team daily. We're also doing a ton of food education and mapping to the food access, the food environments that these patients have. If we're deprescribing costly diabetes medications, we're putting money back into the pocket of the patient. And we also have our 24/7 care team, as well as a health coach monitored patient peer community that allows patients to talk with each other, support each other, ask questions. It's crucial to contrast us with any other diabetes solution or DPP at scale across the nation because we are providers licensed in 50 states. We report to the PCPs all of these great outcomes that we're showing you today, but we don't ask them to do any additional work. We could choose to work in a bubble and reverse diabetes in that bubble, but we choose to advocate for that PCP relationship because we know that many of these type 2 diabetes members have other chronic conditions, complications, CVD risk factors. So we are one component of a larger care plan. And PCPs will be the first to say they don't have enough time to interact with patients daily or titrate down medications 5 to 10 times in the first couple of months. That's what Verta is doing. And so we complement that PCP care. We report every 14 days and 30 days thereafter these great outcomes for their patients. And after they see these outcomes, PCPs ask how they can refer other diabetic patients to Verta. And so we set up those simple referral processes. And from a financial perspective, which is always a concern and always a factor, Verta is going 100% at risk for clinical and financial outcomes. So for the engaged patient population, we have to hit these measures. an A1C reduction of 1 point, weight loss of that clinically significant percentage of 5%. And then the big one, diabetes medication reduction of 40%. This is across an entire plan year. What you don't pay for with Verta is any kind of setup costs or implementation costs or PMPMs, admin fees, et cetera. We are getting paid for these outcomes, and if we don't meet them, you don't pay. These are just some of the diabetes patients that have reversed their diabetes under Verta, and we'd love to see more faces on this slide from many of your organizations, and we're confident that we're able to do this across any population. So with that, we are at the end, and we have plenty of time for Q&A.
Steve, I think to kick us off, one of the first questions we got from the audience was, what are the key tenets of the NIH DPP back in its day? And at its core, how is it different from reversal?
Dr. Ratner?
Sure. So the Diabetes Prevention Program was designed to enroll individuals who had impaired glucose tolerance with an elevated fasting glucose. This was a high-risk patient population. The interventions were either to be randomized to metformin or placebo, and receive usual lifestyle instruction, or to be randomized to an intensive one-on-one lifestyle. That lifestyle program was low calorie, low saturated fat, with an emphasis on exercise. The publication came out in 2002. It revealed that the lifestyle reduced the development of diabetes by 58%. Metformin reduced the development of diabetes by 31%. The Verta interaction is quite different. Now, we do both pre-diabetes and diabetes prevention, as well as diabetes reversal. In diabetes reversal, we're taking individuals who have established diabetes on one or more medications. And with the therapeutic carbohydrate restriction, we're able to lower their glucose, take them off medication, and shift that A1C to less than 6.5, which is non-diabetic, and in a large percentage of individuals, less than 5.7, which is the threshold for pre-diabetes or impaired glucose tolerance. So the goals are different, and the therapeutic intervention is different. Now, the CMS approved diabetes prevention programs through the CDC utilized the 16 sessions that the NIH program initiated, again, focusing on low fat and calorie restriction with increased exercise. We take a very, very different approach, but we have the data to show it works.
Bob. Steve Martin, there was a question just asking to clarify your current status. Are you taking medication still or not? And just understanding your current state in terms of restricting carbohydrates.
No, I'm not taking medication for diabetes type 2. I still take medication for blood pressure, which I've been on for 40 years. I'm back down to what I was taking 20 years ago, so about a 50% reduction in those medications. I maintain the diet, yes. The diet is quite satisfying. That many of participants that I know who have gone through it find the diet very, very satisfying. And your hunger, my hunger dropped because of eating the higher fat and higher green vegetable content and lowered the starch and carbohydrate, especially refined carbohydrates. So I did find my glucose started to uptick in late year 2, and I do use other techniques that Verta's helped me with at arranging different times the day that I eat. And I still can splurge from time to time if I'm at someone's birthday party and a little sliver of cake. I will notice, I usually check, and I notice the next day I have a slightly higher morning glucose, but it normalizes very quickly. So my sensitivity to carbohydrates have never, I expect it never to go away, but I found a way that's much more enjoyable to maintain this diet over long term. And the way I feel and not having medication is the biggest motivator. And I do think with a lot of disease maintenance programs, we don't consider this factor in consumer compliance. It's huge. And it was for me. It was enlightening. And it made me think, what had I been doing to my customers by not engaging this?
Thanks, Steve. Obviously, the focus of this webinar is on type 2 diabetes reversal, and Verta is also doing pre-diabetes as well under the same model and showing tremendous outcomes. But Dr. Ratner, there was a question about the future of Verta and this care model. Do you see Verta expanding to any other conditions in the future leveraging this model, and how would it work?
I think that the coronavirus has completely changed our concept of healthcare delivery. The idea of having waiting rooms where patients are waiting hours for their appointments to be seen for 15 minutes every 3 to 6 months is simply not a viable approach to any chronic disease. Currently, Verta has an intervention and a platform that work. And they work based on the impact of the therapeutic carbohydrate restriction. So we know that it improves diabetes. We know it improves prediabetes. We know that it improves high blood pressure. We know that it improves sleep. We know that it results in weight loss. Those are the obvious ones for expansion. We think, and we have some preliminary evidence to suggest that we can improve cardiovascular outcomes. When you look at cardiovascular risk factors, they fall. You put that into a risk engine, and what we see is that we decrease the 10-year risk of a cardiovascular event by 17%. So we think that cardiovascular disease is a potential target. We think that liver disease, non-alcoholic fatty liver disease and non-alcoholic steatohepatitis is a good target because we normalize liver function tests, we reduce liver fat, and we think we may be able to reduce fibrosis. Those data are yet to come. We look at inflammatory markers and a whole variety of different inflammatory markers from TNF-alpha to a variety of interleukins. We lower inflammatory markers almost universally. 23 out of 26 inflammatory markers improve. We think that this is actually a critical piece of the COVID-19 mortality. What kills people in COVID-19 infection is in fact a cytokine storm. All of those cytokines that go up when people are dying of COVID-19 are suppressed by our nutritional intervention. And that may be why the mortality rate is related to glucose. And so we see a whole variety of different areas that we could potentially be going into. But we are a data-driven company. We'll produce the data before we actually start marketing that.
Thank you, Bob. One other follow-up question is, how would you address skeptical doctors, especially with lipidology issues of this particular medical nutrition therapy, even with the outcomes at hand?
So doctors are convinced by data. They may be skeptical of the data and they want to see more than one paper demonstrating it, but data is what drives physician decisions. We're trying to produce all of that data. We know that a high-fat diet in combination with a high-carbohydrate diet is atherogenic, no question about it. But the moment you lower carbohydrate intake, the atherogenesis of the lipid component, of the fat component, actually decreases. And they're very good data to show the relationship of atherogenesis with the degree of carbohydrate intake as opposed to the degree of fat intake. So that's really the direction that we're going in. What we hope to be able to do is to show that atherogenic lipoproteins shift from bad to good with our intervention. Those data are currently under review.
Thank you, Bob. Steve Martin, there is a question about your experience in the past with DPP. So anecdotally, what were the roadblocks really adopting DPP back in the day? What can be done today by health plan leaders to bridge the gap between evidence, policy, existing programs, and practice?
So I think it was more conventional wisdom. I think the same reason that a number of health plans haven't adopted Verta, there's a very strong commitment to the only way to treat diabetes is with medication and a diet that still is very high in carbohydrate. Now, slowly, as Dr. Ratner's pointed out, that's changing in the literature, but it's still not widely adopted. And I do think it's the nature of a health plan to follow, if you will, the golden mean of practice instead of trying to lead that. So I do think that's what the sluggishness in entering. As I said, I do think there's huge flaws in existing diabetic maintenance programs, which I experience because, again, most recommend diets that are not preventive yet and don't follow even the latest data from the ADA and glucose restriction, and don't provide the consumer with the kind of support and guidance that Verta can on how to make that leap. So that was so. The other part was my personal physicians. None of them thought there was anything else to do. Now, my physician, the way I engaged him to support Dr. Ratner, I looked at him and said, look, every 2 years you're adding medication. I'm still on the edge, not getting better. This doesn't harm me. I'm not going off medication. You're going to follow all along. Why can't I try it? There is no risk. And everything you're offering me is putting me at more risk. He immediately changed his position with me and said, yeah, I'll try it. Well, now he is a very big proponent of the program because he's seen it work with not only me, with others of the patients, his patients.
Great. Thank you, Steve. Well, I believe that's all the time we have for questions. I do want to thank our panel, Steve Martin, Dr. Bob Ratner. Appreciate everyone's time. The slide up right now allows anyone to ping our team for additional questions or time to discuss more. And everyone have a great rest of the week. Thank you so much.